I'm Angela Sanford, and I'm a professor of geriatrics, assistant professor of geriatrics at St. Louis University. I did my medical school at Mizzou and then residency and fellowship at SLU, and I've been done for about 3 years. I started working on a hip fracture study. I hadn't really, as a faculty member, done a study yet, and so they had this hip fracture study that ortho wanted geriatrics to collaborate on. And so I was the lucky one that got to work on this study, and I realized that I didn't know much about hip fractures in old people. I knew a lot about old people, but I didn't really know. I thought I knew, but when I actually started to work on this study, I thought, you know, how am I going to teach the residents best knowledge in hip fractures? So I went through and kind of developed this lecture to really help myself learn what our standards of care are, and then I've been using this to try to teach the residents, and I've done this lecture several times now, so hopefully by now all the kinks are worked out and it goes smoothly, and hopefully you guys can learn something too. When a hip fracture patient is admitted to your hospital, does that patient get admitted to internal medicine or family practice or ortho? So they all go to ortho. Okay. And how does ortho tend to do with these older hip fracture patients? Okay, okay. So I think about, I would say 10 or 15 years ago, our hospital realized that maybe ortho's strengths weren't lying in taking care of the patients after the fractures. You know, they could fix the fracture just fine, but in terms of dealing some of the, you know, with some of the post-op problems that our elderly people have, like delirium and such, you know, that maybe medicine or, you know, ideally geriatrics might be a better place. So we have this rule that anyone over 70 that gets any sort of fracture, like whether it's arm or leg, gets admitted to the medicine service with sort of an ortho consult. And I think it's done our patients a better service. You know, I think that we're able to attend to their needs a little better that way, and everyone's happy. You know, ortho gets to do the part they love, which is the surgery. Oh, it's just, okay. So anyway, that's kind of where I'm coming from. I don't have any financial disclosures. I'm actually not getting paid for the study. At our hospital, somehow orthopedics is getting paid, and I'm just the geriatric consultant that's kind of running the show in terms of the medicine management. So, yeah, and feel free to interrupt at any time. I want this to be informal where we can talk back and forth. So if you have questions, just let me know. So today we're going to actually start with a case that I took care of when I was on the inpatient service. We'll talk about hip fractures. We'll talk about best management and treatment practices, and then I'll discuss a little about the study that I'm doing, but it's not the majority of this lecture. Okay, so we'll start with our case. So when I was on the inpatient service as an attending one weekend, I was covering just for the weekend, we had a patient that had come in a week prior. So it was an 83-year-old white female who presented for fall with left hip pain. She was getting up at her assisted living overnight to go to the bathroom, and she tripped and fell. She laid on the floor for 2 hours before she was able to crawl and reach the emergency pull cord in her bathroom. When she got to the hospital, they found that she had a left intertrochanteric fracture. Orthopedics was consulted, and they wanted to take the patient to the OR in the morning. But of course, they call you in the middle of the night and say, we need medical clearance. You know, our attending wants to come in at 7 a.m. and operate on this lady. So past medical history was significant for dementia, hypertension, coronary artery disease, recurrent falls, and arthritis in her knees. Medication, so she was on basically the medicines we'd use for medical management of CAD, so metoprolol, atorvastatin, aspirin, lisinopril. She was on meloxicam for her arthritis, and then Aricept and Namenda for her dementia. So in terms of social history, the patient was living alone in assisted living. She was widowed. She had 4 grown children. She was using a walker for ambulation. She was fairly independent with her activities of daily living, but needed some assistance with bathing primarily for safety and fall risk reasons. She was needing assistance with all of her instrumental activities of daily living. Are you guys familiar with the difference between activities of daily living and the instrumental activities of daily living? Is that jargon that you guys use or talk about when talking to your older patients? So activities of daily living, there's 6 of them, things like bathing, dressing, feeding, bowel and bladder continence. Those are examples of activities of daily living. So those are the essentials that you really need to have down really in order to live by yourself. And then the instrumental activities of daily living, those are things like cooking, cooking meals for yourself, Shopping, do you do the grocery shopping? Finances, who manages those? So those are things that you might get away with if you have some impairment, but you're living by yourself, but you're going to need some assistance outside to help you, whether that be family or spouses or whatever. So whenever I interview older people, it's really important to me, what can they do for themselves? What do they need help with? Where were they at and where are they at now, sort of thing. So we talk about ADLs and IDLs a lot in geriatrics. This particular patient had no smoking, and she would only drink at the monthly assisted living happy hour, where there's a 2-drink maximum. And I work in an assisted living, and this happy hour is the place to be. They have like their box of Franzia wine, and they can have 2 glasses, and it's really fun. They play some bingo and play some card games, and it's great that that people are still able to have that kind of quality of life while they're yet in a little bit of an institutionalized setting. This particular patient had fallen 4 times in the past year. So in terms of family history, father died of TB and mother died of old age. Review of systems is positive for left hip pain, back pain, constipation, dizziness, particularly on standing, dizziness upon standing. So she doesn't climb stairs because of the arthritis in her knees, and the assisted living is all on 1 floor. And why did we ask that question? We asked it because it's going to be part of our medical clearance. So physical exam, significant for blood pressure, low blood pressure of 105/70, heart rate 50. She was bradycardic. She had a 2 out of 6 systolic murmur at her right upper sternal border. Her left leg was shorter, so I couldn't find a picture of the left leg being shorter, so just pretend that's the left leg instead of the right leg. And it was externally rotated, and she had some mild swelling over that left side. So that was her x-ray, or what her x-ray probably looked like. Her lab work was all normal with the exception of she had some mild hyponatremia and some mild anemia with a hemoglobin of 10.7. Her creatinine was 1.5. We don't know if that's because she laid on the floor for hours or if this is really her baseline. Right. No idea. And that's the x-ray showed the left moderately displaced intertrochanteric fracture. So, let's see. Okay, so what do you think may have contributed to this patient's fall? Thinking back to her exam, thinking back to her medicines. Right. What other things?
Inadequate vitamin D supplementation.
Okay, definitely.
Failure to screen for osteoporosis.
So it looked like in her vitals she was a little bit bradycardic. She's on metoprolol, that in consideration. Her dementia medicines, Aricept and Namenda, are notorious for causing orthostasis. So you're right about the orthostatic hypotension. You can imagine the scenario. It was dark. She got out of her bed, stumbled out of her bed to go to the bathroom. Maybe she tripped on her slippers that were sitting next to the bed, or maybe she forgot in that moment to grab her walker, which was also next to the bed, or tripped over that too. Low vision, maybe she has visual impairment and just added that with the nighttime being dark. She got up, was disoriented, she was a little dizzy, and down she went. And how do we provide medical clearance? Or I guess the politically correct term would be risk stratification. How would you do it when ortho calls you and says, we need this right now? Google it? Okay. That's always a good middle of the night resource. I'm glad that you're thinking that way. That's sort of what this whole lecture, in the essence, I'm going to talk a lot about risk stratification, but that's what I guess my point is that, an older person is not going to do well without getting their hip fracture fixed in almost every scenario. There's very few scenarios that I recommend against it. So, but you'd be amazed at how many people are like not thinking along those palliation lines. They're like, but there was that heart murmur, but there was this or that, or So you're far advanced. Yeah. Is this patient medically cleared for surgery? And you kind of answered our question. Okay, so.
For that decision rests with the surgeon.
Right, and anesthesia, right? It's not really even about our decision because they, believe me, will do what they want in the moment that they want it. So how did we come to this where we need this risk assessment? Well, in the 1970s, Goldman came out with the first cardiac risk index. And you'll notice there's some like crazy things that I don't even know what they mean or what the significance of them are, such as greater than 5 PVCs per minute. What does that mean? I don't know. But basically, they found what they thought was important at that time, where they figured these 9 risk factors. They assigned patients 4 risk categories. But clearly this was a good initial start, but our thinking has evolved. In 1999, we came out with the revised cardiac risk index, so that's the RCRI, and this is what we use more today, algorithms based off of this. So it was developed from independent predictors of adverse perioperative cardiovascular events. They did this retrospective chart review in 2,800 patients and found what's most important in patients undergoing surgery, what determines who does well and who doesn't, from a cardiac standpoint. And then they prospectively validated it in 1,400 patients. So these are the things you'll see today. So number 1, high risk type of surgery. Number 2, any history of ischemic heart disease. Number 3, history of congestive heart failure. Number 4 is a history of CVA and, diabetic on insulins. Number 5, and then anyone with renal failure with a creatinine greater than 2. And so those are the variables we look at, and then they're assigned to these risk categories. So what would how many risk factors would our patient have? So think back. So are we going to say this is a high-risk type of surgery? By pure definition, which we'll go over in the upcoming slides, any sort of emergent or urgent surgery is supposed to be classified as high risk. Here's a lady that laid on the floor all night. Her creatinine's not probably where it should be. She's hypotensive, bradycardic, so you're not entering her into the surgical world in the most ideal circumstances. So it's probably a little bit higher risk. So that would be one variable. We think she has a history of ischemic heart disease. We don't really know. People get these diagnoses and they're carried on in the chart for 20 years and you don't really know what it means. Like maybe one time she came into the hospital and said, I have chest pain, and it really wasn't cardiac, but somehow that diagnosis is going to stay with her forever, although she is on medicines for medical management. So we just don't know really the history there. So she definitely has 2 variables, possibly 1 to 2, I would say. So that puts her at still pretty low risk of complication. We also look at cardiac risk assessment in terms of functional capacity. This actually is probably more important than, what risk factors do you have? How are you functioning with those risk factors is really what this is getting at. So we measure functional capacity in METs, or metabolic equivalents. So there's an example of METs. So how many METs would our patient have using that little chart on the right? I mean, we don't really know. I don't know if she'd be able to climb stairs. She probably has at least 3, maybe 4. I don't know about her stair climbing ability. I'm guessing she's not walking very fast with her walker in the assisted living, so I wouldn't put her really above 4. Patients with excellent functional tolerance are unlikely to experience adverse cardiac events, even with risk factors. So, you think of the guy that had a CABG but now plays golf every day and walks 4 miles a day. That person, they have that risk factor of CABG, but tend to do better because they're functionally fit. So we really kind of think that functional capacity is probably more beneficial or more in assessing risk. So this is sort of our algorithm. So we can start at step 1 and kind of follow it. So is this a need for emergency non-cardiac surgery? No, it's not really like she has to have it the second. And then going down to step number 2, does she have active cardiac conditions? The answer is no. So going to step 3, is it a low-risk surgery? It's not really low risk, so no. And then does she have good functional capacity? She might have 3 to 4 METs, so I would probably say no or unknown. So going down to that bottom category here, she has probably 1 to 2 clinical risk factors, we decided, and it's an intermediate risk surgery. So our answer is we're going to proceed with the planned surgery with heart rate controls. She's on a beta blocker, or consider non-invasive testing if it will change management. So that's the key. Will it change our management? So this is the stratification of non-cardiac procedures. And our surgery is urgent or emergent, so it's a higher risk procedure by definition. So other predictors of overall mortality and morbidity after surgery is not just cardiovascular. We already talked a little bit about renal failure. Dementia in itself is a poor predictor. Low serum albumin, so anyone that's malnourished obviously is not going to do as well after surgery. And then of course prior level of function is going to dictate outcome. So hip fracture is considered an intermediate to high risk, like we talked about, because it's an urgent procedure and it's usually in the setting of trauma. Older patients in general are more likely to have risk factors and other comorbidities. They're also more likely to be functionally impaired and mentally impaired. Falls and fractures are markers of frailty, which is a geriatric syndrome, and these are independent predictors of poor outcome. So let's go back to our case and find out what happened. So someone was concerned that the patient was bradycardic and had a heart murmur. So they consulted a cardiology and an echocardiogram was requested. The patient came in early on a Friday morning. So at our hospital, we don't do non-urgent procedures or echoes or Dopplers or anything on the weekend. So this lady laid in bed until Monday when she got her echo. By Monday, she'd been in bed for over 72 hours and her left lower extremity was extremely edematous, like even more so than just a fracture would cause. So they ordered a Doppler, which was done the next day, and it was positive for a DVT. She was scheduled for an IVC filter because obviously you couldn't anticoagulate her and then send her to surgery. But her procedure for the filter got bumped by emergent cases for interventional radiology, and so it wasn't done until Thursday. So her hip fracture was finally repaired on Friday, which was a week after she was admitted. And the surgery was fine. It was uneventful. Rehab placement took several days after that. And then unfortunately, when I came on that weekend was when she was supposed to be leaving for rehab and she was really confused. And we did a little workup and it revealed she had a UTI. And then the rehab doctor was like, oh no, she can't come until she's had 2 days of antibiotics. I don't want to, take a chance to confusion something else. So she stayed with us for like a week and a half. And do you think this patient's stay had to be so long and complicated? No. So what could we have done differently? Yeah, right. Was it important to our management at the time, knowing exactly what it was? Right, and you're not going to do that. And really, even if she, say, developed heart failure after the surgery because of this valve, what would we do? We would diurese her with Lasix. We would just, control her fluid balance, which we would have done anyway, whether we knew it was aortic stenosis and how severe, etc. What other things could we have done differently? I don't really know the answer to this, but, did she have a Foley in after the surgery that caused her to get the UTI? Did they leave it in for several days? We didn't really pay attention to it, and that maybe that's what led to her UTI. I don't really know. Who knows? Because if you think in an older person, the likelihood of them staying on, especially someone with dementia, it's so confusing when a demented person's laying in bed and they're not thinking clearly and there's something squeezing on their leg. I think it makes people delirious and agitated and they're constantly trying to rip them off. Like, what is this strange thing that's giving me a leg massage? So I don't know, but that's a good question. Yeah, or did they say, oh, I'm sure she's going to surgery. We don't need to start it yet. We'll start it after surgery. And then the surgery came and went and no one really paid attention to that. Mm-hmm. Right. Okay.
Or I don't know what the location of the DVT was. If it wasn't a large proximity.
Yeah.
The greenfield's kind of pointless,
right? And the funny part is I don't remember what the echo showed. So it must have been insignificant because it never came up again. Like I never even thought about it. Once I got in service and they told me this long, sad story, I'm like, wait, why has this lady been here a week and a half? Oh, and then I looked at the echo and it was meaningless. So when I went to write this case, I kept thinking about this lady, but I couldn't even remember what the echo showed and I didn't remember her name. So I think it was insignificant and did not change our management for her. So I want to talk a little bit about non-invasive cardiac testing because we do tend to order it probably more than we should, in these pre-op clearance cases. And I think we need to really keep in mind, will the results of the echo, the stress test, whatever, change our management? That's the big question. So if this lady had a, stress test, say, or whatever, what would our options have been if it were positive? So we could either, give her a cabbage or we could give her a stent or we could optimize our medical management. So based on her revised cardiac risk index, she was at 2 points. So it just said, med management only really and testing only if it changes the management. So there was a trial that looked at this. It was called the CARP trial. It was actually done at the VA. It was a randomized controlled trial. What they did is they took patients that were scheduled to undergo elective vascular surgery and had some known risk factors or had known coronary artery disease. They were patients that were sort of on the borderline of needing something done versus not. So they did. They randomized these patients to getting a CABG or getting stents versus medical management only and just sort of delaying the vascular procedure. And what they found is that there was no difference in 30-day or 2-year mortality rate of these patients after they ended up having the surgery. So the patients that were under just medical management did fine. And that's sort of where our thinking in cardiology changed to medical management is often equivalent to getting a stent. Because if you put stents in people, that's going to delay their surgeries, you know, forever, because you're going to be on blood thinners, you're going to be on Plavix, and, you know, you need to be off the Plavix for a week before the surgery, and you need to be on the Plavix for 1 to 3 months, you know, so stents, they may increase cardiovascular events immediately afterwards. It's not clear how long to wait after a stent placement for surgery. Most studies suggest waiting 6 months, and then you're still have that complication factor of using antiplatelet agents and the risk of bleeding. And so in summary for this part of the lecture, hip fracture surgery is considered emergent. Preoperative cardiac testing is of low predictive value. And perioperative beta blockers are indicated only if they're indicated anyway. And no evidence that urgent revascularization benefits, and stenting actually may be of harm. So now on to hips. Okay, so our hip joint actually has the largest range of motion of any joint in our body with the exception of the shoulder. So just kind of to review the anatomy, you basically have the head of the femur, which articulates with the cup-like acetabulum, and both of these are covered by a real thick fibrous capsule, allowing for a wide range of motion. And blood supply is everything. So I never understood how we decided what kind of surgery people underwent after their hip fractures. You know, is it a full hip replacement, a partial hip replacement, or nailing? But it turns out blood supply is the answer. So when we talk about treatments, we'll go over that. But basically, these blood vessels here are really small, and they can be easily torn. You imagine if you break your hip right here, you're going to tear all those blood vessels. And so that's why we see the anemia that we see oftentimes after a hip fracture and hip fracture repair, is that basically this blood loss just goes straight into the joint. It's, you know, large into the pelvis, and it can be a sink for a lot of blood. And with, not even realizing that all of these arteries were torn in the process. And so it makes a big difference with hip fracture repair, because if these are damaged, this is at risk for avascular necrosis. So that's basically lack of blood supply, and that bone will actually die. So blood supply is very important. So in terms of epidemiology, there's greater than 300,000 cases of hip fractures in the US. The occurrence rate increases with age, of course, and it doubles every 5 years after the age of 60. So half of hip fractures occur in those greater than 80. Those at highest risk are Caucasian women. They have a lifetime risk of 15% of getting a hip fracture. And we care because 25% of patients die within a year. So that's a huge mortality. And it's kind of a slow, painful death with a lot of suffering. Oftentimes, it's sort of, you know, one bump after another, and then eventually the patient passes. Risk factors include age and female sex, race. White women are again at the highest risk. History of dementia, osteoporosis, decreased mobility, and CAD and CHF also increase your risk. And in terms of we'll talk about that when we talk about the type. I'll hold that thought. So in terms of incidence, of course, the incidence is highest in those greater than, you know, 84, or older age up here. And I think actually the incidence has started trending down since the 1990s, because that's when the bisphosphonates came out. So we've actually seen a dip in the hip fracture occurrences after osteoporosis was more adequately treated. And this is mortality. As you can see, it's pretty high, especially for men. 35% of, you know, elderly men will pass away within 1 year. Higher, it's definitely higher than in women. And another reason why we care. So not only do we care about mortality, but the risk of disability in various ways. So unable to walk independently. 40% of patients after hip fractures don't walk independently without devices, again, without their walker or independently at all. And many of them have difficulties with their activities of daily living. And when that starts happening, these patients aren't able to live at home again, by themselves at least. And in terms of what types of hip fractures, so the most common type in older people is the femoral head, or the femoral neck fracture, sorry, the femoral neck, so usually right in there. Younger people and in higher velocity traumas tend to get the other types of fractures. In older people, it's interesting, you tend to see like a clean break. You know, you have one break and that's it. In younger people that are in car crashes and stuff, the whole femoral head is usually shattered. And those are actually much harder to treat than just the older person type of fracture from osteoporosis. In terms of treatment here. So I did want to talk a little bit about decision-making capacity, because obviously if you're going to operate on these patients, you need to ask them if they consent. So how do you determine decision-making capacity? Any thoughts? How do you know this person can consent to their surgery? I'm going to get ready to, replace this patient's femoral head. Are they able to tell me that that's okay? Yeah, and I don't even know that date's so much important, because there's many of us that don't know the date and we're still pretty decisional. I think understanding the consequences of their decisions is what we really look at. Can this lady tell me, yes, I fell and broke my hip and here I am in the hospital with my broken hip? Either I have surgery or I don't have surgery, and if I don't have surgery, I might not be able to walk again. If I do have surgery, I could die, kind of at least understanding some of the risk of what she's saying. So there needs to be consistency in response between interviewers. Like, that's the worst, when the patient tells you something and then tells the attending something later. So on some level, there needs to be consistency. The patient is continuing to say, yes, I'm okay going to surgery. Yes, I agree. Is the patient aware of the fracture and understands the reason for surgery? Do they give an understandable reason for consent or refusal? Is their answers consistent with prior life events and decisions? I think of this like maybe a Jehovah's Witness that doesn't, all life has not accepted blood products, and here in the hospitals, okay, give me some blood. Maybe they're not thinking clearly, because their entire life, they've been against that. So that's where you get the POA involved. Yes, and you can obtain the POA input if there's any questions. So in terms of non-operative management, I can only think of like 2 times that I've really recommended this. Usually it's in a patient that is basically hospice or dying. You think they're going to die of something else fairly quickly. So it may be an option, a demented, very ill terminal patient, if you can make them comfortable with medications. However, most of the time we do consider surgery palliative, even in non-ambulatory patients, because of pain control. If you don't get your hip fixed, you might be stuck in bed. You might not have any range of motion of that hip joint to even allow you to get up into a chair. So is this person, are we comfortable with them lying flat, for the rest of their life, essentially? So there's sometimes confusions about patients that are DNR, DNI. That does not mean do not treat. You can bring them to the hospital, and then, the surgeons always make the patient's full code during the surgery, and then you can institute the DNR, DNI afterwards. I had one nursing home patient that was on hospice because she weighed 75 pounds and she had dementia and wasn't eating, and she fell out of bed and she broke her hip. And so she went to the hospital, and the family called and said, what do we do? Should we do an operation or not? And we sort of talked through the scenarios, and we decided she was 75 pounds. She may never heal that wound, so we decided not to do it in her, because I really thought she was going to die in the next couple weeks, really. And she came back to the nursing home and lived 2 years with that broken hip. And I had her on scheduled morphine, scheduled Roxanol. She actually was able to stand on it somehow. After a couple months, she could stand on it and transfer to the toilet. She was able to sit up, although she preferred to lay in bed most of the time. But there's always surprises, right? She died and she weighed like 65 pounds, and she lived that way for 2 years. So, okay, so what type of surgery is done when? So do you guys know the different types? So there's intramedullary nailing or screwing. There's a hemiarthroplasty, where basically the head of the femur and the proximal part of the femur shaft is replaced with the metal rod. So that's here. And then there's a total hip replacement, where the acetabulum is replaced and the femoral head and neck. So when do we do that? I'm going to go back to our blood supply picture real quick, because I think that illustrates it the best. So basically, if, like I said before, if there's any disruption in this blood supply, you're at risk for avascular necrosis. You're going to have to replace this whole femoral neck and head. If the fracture occurs somewhere down here, then you might get away with putting a nail in, you know, nailing it. Or if it's like right here, you might be able to nail it that way. Arthroplasties, so full hip replacements, they're reserved mostly for elective cases. So patients that, you know, in their 60s and 70s that are coming in for a hip replacement, those are where you do the full arthroplasty. So surgeries are longer, they're more technologically advanced. So in the setting of trauma, someone falling, they have osteoporotic bones already, you tend to try to do less. So usually just a half a hip replacement or nailing if you can get away with it. So. Okay. And then I wanted to talk, spend the last part of our lecture on talking about best practice in perioperative care. So after these patients come back to the OR, how are we going to get them back to walking, and how are we going to get them back to being functional as quick as possible? So we'll go through each one of these in detail, but basically the best practices include getting the patient operated on within 48 hours. Patients do much better if they have early repair versus what you saw in our case where the patient laid in bed for a week and had all these complications. So goals for surgery within 48 hours, we always want to focus on pain control. And early mobilization is also important. And then, of course, DVT prophylaxis, delirium prevention and avoidance, osteoporosis treatment, and then early planning for discharge. So we'll go through each one of these. So surgery within 48 hours, surgical delay independently impacts mortality. As you saw, our patient could have died, you know, sitting there a week. So if delayed by greater than 48 hours, they found that 1 month mortality is increased by 17%. So the mortality morbidity of waiting stems from the immobilization. So DVT, PEs, people getting, you know, pneumonia, weakness, developing pressure ulcers. Overall, they have decreased quality of life as they lay in bed, and further impairment in their ADLs and IADLs. And people get depressed, which, you know, doesn't motivate them to move. So in terms of pain control, I sort of have my little algorithm after a patient has hip fracture surgery. I start Tylenol, scheduled Tylenol right away every 6 to 8 hours, because a lot of our older people won't ask for, you know, pain medicine. So I figured this is at least providing some sort of basal pain control. The goal is really to cut down on the amount of narcotics you're using because those can cause confusion. But again, you want to treat pain because pain in itself can precipitate delirium. So usually within the first 24 hours, I do IV morphine or IV fentanyl with my scheduled Tylenol. And then after that, I try to kind of cut it down, bring it down to PO, so Percocet or Norco. And again, it may be scheduled if the patient can't ask for it because we don't want them to be in pain.
Would you leave the meloxicam on?
No, I don't use meloxicam in my older patients. I just threw that on there. I think it's too hard on the kidneys, and I don't really like the cardiovascular risk factors associated. I find it elevates blood pressure. So I'm a big Tylenol person, telling everyone just schedule a Tylenol. Elderly people can have up to 3 grams a day. So I know it's not quite as effective, a lot of people don't feel, as NSAIDs, but it's probably safer. So in terms of early mobilization, addressing weight-bearing status, you're going to be the ones that do this. Ortho forgets this, right? Because they've operated, so their big part of the whole process is done. So this post-operative stuff is up to us a lot of the times. So most patients with uncomplicated procedures, so just our normal hip fracture repair, should be weight-bearing by post-op day 1. We should be getting them up, starting physical therapy on post-op day 1. It's different if it's a distal femur fracture or a pelvis fracture. Those patients are non-weight-bearing, but in terms of a fracture that's been repaired, we've really had to work with ortho in our hospital because all the ortho attendings will say this, but it just doesn't trickle down to really happening. And so you'll have physical therapy come and say, oh, well, we can't get the patient up because they're bed rest. You know, this is post-op day 2 or 3. And I'm like, no, wait a second. They shouldn't be bed rest. You know, talk to the ortho attending. I'm sure it wasn't a priority to change that in the chart. So they're actually they've done orthopedic studies on this because it was always a controversial topic. In other countries, it still is actually. We have a doctor that's in China right now visiting geriatrician trying to set up a geriatrics program, and he says he cannot get people out of bed after really any kind of surgery, but particularly hip fractures, because they're worried that there's going to be like a dislocation or that, you know, a non-union of the fracture repair. But they did a study looking at this in the U.S. and they found that really unrestricted weight bearing in elderly patients is okay, and that the rates of implant failure were the same whether the patient laid in bed or got up and used it. This is an important topic too, is DVT prophylaxis post-hip fractures. What are you guys doing? What's your standard? Do you address it? Do you do STDs and then what?
And Lovenox.
Okay.
Every patient, every time.
How long would you continue the Lovenox?
35 days post-op.
Yes. Okay. So that's good. Or I'm pushing more towards using the novel anticoagulants if I can, only because I don't want to give someone a shot for 35 days. You know, like it seems a little bit inhumane a little bit if I could just give you a pill with the same effect, if they qualify. So we'll talk a little about that. So we started with our SCDs. The data's not great, but they show they're better than nothing. Aspirin, of course, is better than placebo, but not as effective as other options. We have some community older orthopedists that are sending me patients in the nursing home on 325 of aspirin twice a day, and that's their DVT prophylaxis, and I just don't ever know what to do. Like, bless their hearts. But I don't think the data is there for that, but I just want to hug them, though, because that's such a good thought. So, yeah. So up to 50% of patients without prophylaxis can get DVTs. And obviously, proximal DVTs are worse, and 27% of patients develop those without DVT prophylaxis. Pulmonary embolism causes 15% of deaths after hip fracture repair. So we're definitely still under-treating. And of course, the factors that increase the risk of DVTs are our patients, the advanced age, going under general anesthesia, delayed surgery. So in 2012, the chest physicians, or the pulmonary physicians, released guidelines exactly on this. So we finally had DVT guidelines in orthopedic surgery patients. And they get they start broad and then they get more specific. So basically in the end it says down here, there we go, patients should have DVT prophylaxis for, 35 days actually is right here. So it gets more specific, and basically, everything's better. It'll started with SCDs and kind of got more specific. So I just want people to be on it, but really I try to use Xarelto or one of the pills more because I think it's easier on the patient. My patient in the skilled nursing undergoing rehab, I hate to think of them getting a shot every day for 35 days, but if they have a history of GI bleeding or renal failure, obviously it would be contraindicated. Coumadin is also a possibility. Most renal patients get Coumadin, so yeah. And also Lovenox is quite expensive for the nursing home. I think it's about $2,000 a month, and I think the novel anticoagulants are probably closer to $450 or $500. Heparin's okay too. I do see people on heparin, but really you want to give them 90 shots over the next month. So trying to just make things a little easier on the patients and the staff. So one of the problems that we have post-op is delirium. So you probably all have gotten called on the patient that is climbing the walls and ripping off their telly and pulling off their oxygen, and what do we do? So it's the most common medical complication following hip fracture repair. There's a 30% risk in our older patients. Usually appears on post-op day 2 to 3 once the anesthesia wears off, and it can be a marker of bad outcomes. So increased mortality, increased risk of institutionalization or needing placement after the hospital stay. It always increases the length of the hospital stay, and it interferes with their ability to participate in PTOT and really get back and be functional. So it may not be entirely preventable, but is more manageable if you promptly recognize it. So in terms of prevention, early mobilization, getting the patients out of bed, opening the blinds. How many times have you come in, the room is dark, the lights are off, the patient's laying at an angle in the bed, half naked? That's like the classic delirium sign, right? Their gown's off on the floor and they have no idea what day it is, what time it is. So really opening the blinds, trying to set about a schedule, monitoring for constipation or urinary retention. I've seen that many times where the guy hasn't peed and his bladder has 2 liters in it, and that would make anyone delirious. You want to minimize narcotics, but you want to provide adequate pain control. And minimizing their medications is a good time. I get a lot of consults from cardiothoracic surgery saying the patient's delirious after their cabbage, and I open up the chart and they're on Benadryl, like scheduled Benadryl. That's highly anticholinergic. That makes all old people confused. So really addressing their polypharmacy and minimizing medications that aren't necessary is important. And then, trying to remove their restraints. So you can picture the hospital bed of the person that's confused. They have their SCDs on, they have their oxygen on, they have their telemetry telemetry on, their IVs on. They're literally just like tethered to the bed and their brain's not processing it, and it could be very scary. Like, why are they holding me down? Why are they tying me down? So really trying to de-restrain them. You know, do we need that IV? Do we need the oxygen, or was it just on, you know, the post-op day or so? You know, definitely discontinuing the Foley, and do we need telemetry? What's the indication? And then the thing we don't do in the hospital, which I don't know that I'll ever make progress on, is letting people sleep. You know, that's one of the things I think in the hospital that precipitates delirium the most, is that people are awake for 24 hours or more. So what do you do when they call you and tell you the patient's delirious? What's your go-to?
Rosarum.
Okay.
There was the Japanese trial from a couple of years ago that looked at Rosarum for delirium prevention.
Okay.
In the ICU, and they gave it to all comers and cut their rate by 90%.
But that was more prevention. So once they get it, what do you do?
So we can still throw in the Rosarum.
Okay. Does everybody know what Rosarum is? It's a melatonin agonist. So it's supposed to be more natural, but it's like high doses of melatonin, the synthetic form. Okay. Do you guys use antipsychotics? It's okay to say yes. I always used them until I went into geriatrics. Okay. Okay. I think I was the nurse's best friend when I was an intern, when I was on night float, because I was like, sure, you want some Haldol? I'll order it for you. Sure, I don't want you to call me again. I'll definitely order it, you know? And then I learned I was not doing a service to my patients, but it took me years. It really took my boss, Dr. Morley, like yelling at me when, you know, he was the attending on my team, like, you did what? And I had no idea it was wrong. But really, there's no approved indication for delirium for antipsychotics. They're not approved for this use. You know, the FDA has this very specific approval guidelines, and they actually, we'll talk about that. So yes, we use them, right, we use them inappropriately. So there's no data that this improves the outcome. It likely makes a delirious patient just more sedated. So they're now a sedated delirious patient. It may improve behavioral scores, but that's because they're asleep. And there's lots of side effects: sedation, orthostasis, worsening delirium, cardiovascular risk, QT prolongation, and sudden death. In fact, the FDA placed a black box warning in 2005 saying that, you know, there's this risk of sudden death and stroke in the elderly with the usage of antipsychotics. I think it's based on this QT prolongation, that it does happen in some patients and then they just die quickly. So I was once there, and I still am trying to educate. What actually works really well, if you can do it, is getting people out of bed. This is in general. I'm not speaking necessarily hip fractures. It's sometimes harder, but actually walking them around. So when I would be on geriatric rounds, when I was like a senior resident and Dr. Morley was there, you know, they'd get the call, this patient's been trying to climb out of bed all morning. Well, we're on rounds, you know, what do you want me to do? And he would say, just bring the patient with us. So I can just remember this one patient we would bring, and he would literally just walk with his little walker, and we would, you know, go in the patient's room, and one of the med students would stay outside with him. And after like doing that for probably 20 or 30 minutes, he got tired, and he went back and he laid in bed. So every morning we just took him on rounds for like 20 or 30 minutes and walked real slow around the hall, and then he was good for the rest of the day. He would sleep. So my husband's actually a surgery resident, and he calls me sometimes and is like, I know you always tell me I can't use antipsychotics, but this nurse is calling me from the ICU and I just don't know what to do. And so I started telling him, I'm like, tell her to walk him around. So it really works. And now he's like preaching it to all the other residents, because he's like, if anything, they'll stop calling you because they don't want to walk the patient. So, or else they'll walk the patient. They'll walk the patient and it works. So he's like, I have yet to have a nurse call me a second time after I've recommended that. And I'm not quite sure. I'm just going to pretend they're walking them and the patient goes to sleep, and it works. So try that next time. So talking about osteoporosis, because this is part of, you know, we need to prevent osteoporosis so we can prevent our hip fractures. So vitamin D and calcium, what do you know? Should we do one? Should we do both?
AAOS guidelines say do both.
Okay. So the evidence is actually for vitamin D. There was a meta-analysis done in 2009 that compared vitamin D with or without calcium to calcium alone, and showed that vitamin D alone resulted in 20% decrease in non-vertebral fractures in those greater than 65. There's controversy regarding the dose. I see people on higher and higher doses, but really I'm sticking to 1,000 milligrams. A lot of people I see are coming on 5,000 and such. I don't know. There's really no need to check vitamin D levels. This was drilled into me early, because most Caucasians are going to have older Caucasians will have low levels no matter what. And it has something to do with the binding proteins. Like my boss is endocrine, so he understands this a lot better, but it also has to do with our assays. Our vitamin D assays are not yet very good. And checking the level usually is about $450 for one lab. And so I only had to have one patient bring the bill back to me like one time and yell at me, and then I never ordered another vitamin D level. I just treat. It's so much cheaper to just put them on 1,000 units a day for the rest of their life. It probably wouldn't even cost $450. So. And in calcium, the jury is still out, but we don't think it really helps. Yes?
Are you recommending that for all patients or just osteoporotic?
I'm recommending it for just, well, how do you know they're always osteoporotic? I start a lot of my older patients on it because it's cheap. We think it reduces fall risk. I wouldn't say I put every patient on it, but I try to hone it down to that.
The reason I ask is outside of the osteoporosis population, I haven't seen a lot of evidence that vitamin D replacement helps.
Right.
There's lots of studies showing patients with lower vitamin D have worse outcomes with that more diet.
And I've seen it too with pain, you know, like bone pain or arthritis pain. So I don't think it's bad to put people on 1,000. Like I said, there aren't any harms that we know of yet. I wouldn't give everyone 10,000 units or 5,000 units, which I've been seeing more and more of lately. But did someone have a question over here?
For an outpatient type setting, is there any specific formulation for vitamin D, or should you just say get some from all?
It's, yeah, vitamin D3. That's the most bioavailable form. They use vitamin D2 when they do the replacement, like 50,000 units weekly or whatever. Maintenance therapy, though, is vitamin D3, 1,000. And then in terms of calcium, jury's still out. Calcium has some risk of, some risk and some side effects. So it makes people constipated. There's some question about whether it increases cardiovascular events. So I don't know that there's enough evidence to show that it helps. So I just tell people, you don't really have to take that. Take your vitamin D. It will help you absorb your calcium from your diet and, go with that. And bisphosphonates, this is another thing that I need to get better at and that I'm trying to through this study. They should really be started on discharge, otherwise they'll never be started. For a while, for many years, ortho was telling us we couldn't start bisphosphonates right away on patients that had a fracture because they thought it impeded bone healing. But the reality, there's been studies done since, it's sort of just a myth. It doesn't. So I think starting them early is good because otherwise it will never happen. And a review of the Medicare data showed that only 20% of patients with a history of hip fracture had any sort of bisphosphonate treatment over 2 years. So this is a really high risk group of patients to refracture, and only 20% of them were treated adequately. Okay, so FOLEYS, just say no, you can do it. Don't let that nurse tell you or that person tell you that you need to have a Foley in because they have a wound. They've got that surgical incision and we don't want to get urine in it. Don't let that happen, because if everybody's doing the things you've never heard that?
I've not heard that.
Like, oh, we don't want the urine to get, they are incontinent. We don't want the urine to get in the wound. So my answer to that is, well, you probably should be changing their pad under them or changing them or even trying to get them up to the bathroom every 2 hours, and urine's really supposed to be sterile in theory, and really changing their dressing. If it gets wet, you change it, So we know that Foleys are very risky and that the risk of UTI after hip fracture is 25% in those that have Foleys. So remove the catheter within 24 hours. I usually give them one night after surgery to keep it in for comfort, and that's it. So let's see, is that it? Yeah. Yes.
Instead of bisphosphonates, have you ever tried doing Forteo?
I am not as familiar with that. I'll be honest. I have not. I've never prescribed it myself. Okay. And I think that we're sort of coming away from because there was this study that was just done that I pulled for this lecture in 2015 that really postoperative bisphosphonate administration doesn't affect bone union. So it's probably a myth that maybe 10 years ago some studies showed when they first came out that we, wasn't done well or wasn't, it's just different now. So I'm doing a hip fracture study. I'll tell you just a little, one slide about it. It's a 12-site international study, basically 2 sites per country, and what they're doing is comparing SLU with the hospital in New York that doesn't have geriatricians. So the SLU patients are being seen by a geriatrician every day, and the New York patients aren't. And there's 2 sites like that in 6 different countries, and they're really just looking at outcomes. So I'm hoping, in theory, I'm supposed to make their outcomes much better, right? After this lecture, you can see that they're just going to do so much better. But we'll see what really happens. I'm a little bit scared. So we'll see. And that's my family. Any questions?
Well, there's some really decent evidence on vitamin D and depression.
Yeah.
Like, I have a list of things that I'm like, yeah, let's just try vitamin D. One of them is depression.
Yeah.
One of them is osteoporosis. Those are big ones. And then fatigue is the other one.
Right. And then pain. Like there's this whole list of things that we think it may impact. So it's probably not harmful. I say, why not give it a shot?
I'd really like to see some randomized controlled trials where they actually do vitamin D. Like I said, most of the evidence is based on the absence of vitamin D.
Yeah.
It's like if the administration doesn't correct it, then what was the point?
Right. Right. Well, thank you guys for being so engaged. It was fun.